All right. Welcome to Project Echo. Happy Friday, everybody. Today, our topic is alcohol treatment in the outpatient setting. Ed Kaiser is going to be conducting this one for us. I'll get through my usual housekeeping things here real quick, and then we'll turn it over to Ed this morning. The usual disclosure of relationships. Again, no relevant financial relationships to disclose. And then our funding statement, we are funding by the State Opioid Response Grant. That's a federal grant from SAMHSA that comes down to us through Nebraska DHHS. And then the same certificate process that we've been doing for the last few sessions here, the same evaluation survey. And then I guess the newer part recently here, the last few sessions, is that I'll email the survey out to you all. We have a new survey form that the NMA likes to use, and you're able to add your name and date within that survey on your own. And again, just holler at me. You've got my email if you have any questions or issues with the certificates. Okay, so we do these in cycles of 4. This is the fourth of this current cycle here. So we will be off in March as our Echo team puts together our next cycle of trainings for April and May. We've got a list of topics that will likely be included in this next cycle. Still subject to change, but it's looking like our topics will be youth and substance use, kratom and 7-OH, case studies on how to start buprenorphine, and ER collaboration for OUD treatment. So more information will be coming out on that soon. You can register for that next series of training, that next series in today's evaluation survey. Just check a box that says, "Yep, sign me up for that next series." Otherwise, we do separate registrations for this, so keep an eye out for information on how to register for that. And as always, consultations are available anytime with our team of experts. So just get in touch with me, and I can connect you with the right one for what your needs are. Okay, I'm gonna stop sharing my screen here and let our Echo panel introduce themselves. Let's see here. Mary, would you like to go first?
Good morning. My name is Mary Ellis. I am a psychiatric nurse practitioner and attorney here in the state of Nebraska.
Thanks, Mary. Alex.
Morning, Alex Dwork. I'm a family physician who does a lot of things, including addiction treatment in South Omaha.
Thanks. Todd.
Good morning, Todd Stoll. I'm a psychiatrist.
Thank you. And let's see, Stephanie, I think I saw you come on here.
Hi, all. Stephanie Bennington, psychiatrist over in Western Nebraska and Rapid City, South Dakota area. Nice to see you all this morning.
Thanks, Stephanie. I don't see John on this morning, so Ed, I will let you take it from here.
Thanks, Will. Good morning, everybody. Ed Kaiser. I'm a family-trained nurse practitioner. I live in Omaha, Nebraska, and excited to be with you guys today to talk about alcohol in the outpatient setting. Will, does that screen look right?
Yep, looks good.
Okay, perfect. So I started my career as a nurse practitioner in the emergency room. I worked there for a couple of years, and then I transitioned into the urgent care. And then for the last almost 8 years now, I've worked with a company called Ideal Option, and I primarily do outpatient treatment for substance use disorder, really across the United States. So in different states, I do a lot of telemedicine, although I'm located here in Omaha. And so my first kind of exposure to patients with alcohol treatment was in the emergency department, where we'd see people that were really, really sick, breathalyzer tests 3 or 4 times the normal limit, and really people that were not in a great spot. I do get the opportunity to treat patients with Ideal Option with alcohol treatment, but it's probably not as primary as like opiates and stuff like that. But I still really enjoyed treating this patient population, so I'm excited to talk to you guys about it today. When I started to kind of prep for this talk, I was hoping to do more of a conversation about alcohol withdrawal treatment in the outpatient setting and how we can help patients with that. But as I sort of got into the talk and was working on it, what I realized is I probably have too much information for one talk, and so we're going to split that up a little bit. What we're going to try to do today is talk about initially some statistics and kind of the scope of the problem of alcohol use. We'll spend a little bit of time on diagnosis criteria. It's relatively simple to do the diagnosis criteria for these individuals. And then I really want to spend a fair amount of our time on the progression of the disease process and just talk about how individuals who suffer from alcohol use disorder, how that sort of progresses through their life. And then as we look at that, we'll also look at the treatment recommendations for alcohol use disorder in the outpatient setting. Look at also some different treatment options that are available, and with that, we'll include the Sinclair method, which I'm one of those people that is very much a proponent for the Sinclair method. I think it's really helpful for individuals. And then we may do some case studies at the end of our time, depending on where we're at, depending on how many questions there are. And then hopefully we'll kind of save the alcohol withdrawal syndrome treatment in the outpatient setting for a future echo presentation, if that works out okay. All right, so let's start with the statistics. So when we look at the scope of the problem of alcohol use disorder, it is a major sort of global health problem, and it ranks 7th among the leading causes of death and disability worldwide. The other thing I think that's relevant for our conversation this morning is most clinicians are going to encounter patients who struggle with alcohol use disorder and the complications essentially in routine practice in just our day-to-day lives. If you look specifically at the United States, there's an estimated 8 million alcohol-dependent individuals, and about 500,000 episodes of severe alcohol withdrawal occur each year that do require pharmacological treatment. So again, we'll kind of look at that in the future of how we can be a part of the solution, especially in the outpatient setting for those individuals. And then again, approximately 2 to 7% of hospitalized patients with significant alcohol use that are admitted for general care are going to develop severe alcohol withdrawal during their time in the hospital. Some more data for you. This is from the CDC. They should be coming out with new data soon, but this is the most updated one I could find. This is from 2020 and 2021, but at that time, 178,000 deaths annually in that time period, and that was about 488 deaths every single day from people who struggle with alcohol use disorder. That equates to an average of 24 years of life lost per person, and essentially 4 million years of potential life lost annually. Of all the statistics that I sort of list when I talk about alcohol use, that one is the one that sort of hits home for me the most. Most people know somebody who has struggled with alcohol use disorder or maybe passed away from alcohol use disorder or is struggling with alcohol use disorder. And I'm no different. When I was growing up, I had an uncle who struggled with alcohol use disorder, and I was really close to my cousins. They would come to Imperial, where I grew up. In the summertime, we'd spend a lot of time together, and so I was really close to them. I really saw sort of the devastation that alcohol caused in my uncle's life as well as in my cousin's life. But my uncle, he passed away from alcohol use disorder when he was 42 years old. And I'm currently 41 years old. I'll be 42 this year. And so when I think about his life, when he passed away when I was a teenager, he seemed like he was pretty old. But now that I'm going to be turning 42, I realize, like, man, he was so young, and there was so much life lost for him. And yeah, so that statistic is one that sort of hits home to me, at least today. And so, again, you probably all know stories of people like that as well, but they're usually the causes of death. And I'll talk more about my uncle as we go along, but the causes of death are generally chronic conditions. So 2/3 of the deaths are related to cancers, heart disease, liver disease, with alcohol use disorder. And then 1/3 of the deaths that are related to alcohol use disorder are from acute causes. So think motor vehicle crashes or alcohol poisonings, suicides, things like that. I mentioned at the beginning that 80% of the work I do is with opiate use disorder and Suboxone treatment and sort of managing that. And I just always like to compare alcohol to opiates as far as misuse in the United States. So as you look at these statistics across the board, you can see that alcohol is worse than opiates, both in just use and misuse. If you want to look at DSM-5 criteria with the population, it's higher in alcohol use. You can look at emergency room visits related to alcohol use and annual deaths. And so again, just trying to highlight that, hey, although we talk a lot about opiates, and opiates gets a lot of attention, especially because of the risk of opiate overdose and the significant dangers of death in that way. Alcohol really in our country is taking more lives on an annual basis, even than opiates are. Okay, so we looked at the statistics, get a better grasp of kind of the scope of the problem. Let's look at the diagnosis criteria together. When you think about diagnosis criteria for any sort of substance use disorder, essentially we just use the DSM-5 criteria. And the way that we do this in the company that I work for is we usually just hand people a sheet with these 11 questions on it and just have them check yes or no. The questions are pretty straightforward around alcohol use. It's in a 12-month period, so that can be any 12-month period in their life. It doesn't have to be in the last 12 months. But alcohol use isn't taken in larger amounts over a longer period of time than was intended. Is there a persistent desire or unsuccessful efforts to cut down or control alcohol use? Do you spend a lot of time obtaining or using or recovering from alcohol use? So essentially recovering from alcohol use is probably more relevant in that question. And then do you have cravings, strong desire to urge to use alcohol? Is it starting to get in the way of your obligations at home or at work? And then are there persistent or recurrent social or interpersonal problems? This is really probably when I start seeing patients the most, is when it starts getting in the way of their relationships. Maybe their significant other or family member tells them that they need to go in and get help. And so this is really a relevant question for people seeking care. Is it getting in the way of recreational activities? Are you using alcohol at times where it's physically hazardous? I think the most common there is just drinking and driving. And then is it having any physical or psychological problems? Are you having any ones that are worsened by alcohol? And then the last couple is just related to tolerance, which is, do you need more alcohol to sort of get the same effect of it? And then do you have withdrawals when you stop drinking alcohol? At the bottom of that slide there, the severity specifiers. So for mild alcohol use disorder, you just need an answer yes to 2 to 3 of the criteria, and it kind of goes down from there. Again, generally speaking, if you just ask somebody about their alcohol use and they tell you why they're there and what's going on, you get a pretty good idea of where they're at on this scale without even specifically asking them every single question. But I do think it's helpful to sort of have a gauge of where the patients fall on the DSM-5 criteria when we see them. Okay, so let's talk now a little bit about kind of the timeline and the progression of alcohol use disorder. And again, this progression has, I think, like 7 different slides to it, or 7 different areas. And so what I'm really trying to highlight here is the timeline of alcohol use and sort of how long it takes. So early on, we call this sort of a low risk or experimental use. Generally, you're going to see this in sort of a teenage population, maybe early 20s. This can look like social drinking. Generally, there's minimal or no negative consequences, although this is a significantly high risk population for, things like motor vehicle accidents and things like that associated with alcohol use. As we progress through these, it's worth saying that, hey, not everybody's going to follow each step. People can kind of go back and forth along this timeline, and that can depend on kind of the environment and treatment options that are available, and as well as some of their genetics. So we progress to sort of the second level here, which is at-risk early problematic pattern. And again, the typical timeline in this area is somewhere between 6 and 5 years. So people are generally in this time frame for quite a long time. And this is where we start to see people using alcohol where it becomes more frequent or more functional. It begins to be used for things like sleep or relaxation, anxiety, coping with stress, things like that. Early warning signs in this area is people begin to maybe drink alone more often. Maybe they're starting to get defensive about drinking, and they're starting to get some sort of side effects of hangovers, post-alcohol use the next day. So the third category here is where we started to get into this sort of hazardous use or recurrent binge patterns. And again, timeline here, some of these timelines overlap, but timeline is 1 to 10 years. So generally people are in this stage of alcohol use for quite a long time. The patterns become a little bit more predictable and routine in this area. There's a higher risk of sort of binge drinking, people beginning to have blackouts. Maybe they're driving after drinking, or maybe they're mixing alcohol with other substances or medications. The clinical markers are increased tolerance. So essentially you need more alcohol to sort of get the desired effect at this point, and you start to see some of the relationship strains. One sort of interesting fact is Nebraska is in the like top 5 to 10 worst states in the United States when it comes to binge drinking. So I'm not really sure how long we've been at that spot, and I'm not sure the reason of it. You know, my joke is that the Huskers have been bad for a long time, and so that could be one of the contributing factors. But again, I just highlight that to say, like, hey, in the state that we live in, there's a lot of people that are using alcohol in a binge sort of way, and so we do need to be mindful of that as we're trying to talk to people about alcohol use. All right, so we get into the fourth stage here, and this is where we're actually just getting into sort of mild AUD, at least from a diagnosis criteria from the DSM-5. Again, timeline, long timeline, 2 to 12 years from onset of regular alcohol use. People begin to sort of like lose control, failed efforts to try to cut down, or they have this increased cravings. And then with other substance uses, people continue to drink alcohol or use the substance despite the consequences of what's happening. A lot of times I see patients when they try to cut back or stop using alcohol come in with these symptoms, and especially they talk about sleep disruption, how difficult it is for them to fall asleep, and they use alcohol to sleep sometimes. They can definitely have some anxiety and irritability in this season or when they're at this stage. And then they do start to get some early withdrawal symptoms, can be possible at this point as well. So the fifth stage here is moderate alcohol use disorder. Again, highlighting this timeline, 5 to 15 years, where people are sort of in this timeline. What changes is that alcohol becomes sort of their central strategy for coping. They start to get into these more significant consequences. It's getting in the way of their work life. Interpersonal conflict is getting worse. Maybe they're starting to have some health issues with it. They're going to have more consistent sort of withdrawal symptoms when they stop drinking. You're going to start having conversations with people. They'll tell you they start drinking earlier and earlier in the day, or maybe they're having that sort of eye opener in the morning to help sort of ward off the withdrawal symptoms. Again, for these individuals, they start to get this sort of escalating shame. They're hiding their drinking. They're maybe drinking more in isolation. And again, for a lot of people, this can be a really shameful sort of disease process just because alcohol is so available. Lots of people drink, maybe their friends drink, maybe they can control it in a different way. And so a lot of times people don't want to talk about it just because of the shame associated with it. The sixth stage here, the way it is laid out, is severe alcohol use disorder. And again, this is when we get more into dependence and high harm. And this is where we get into the timeline of like sort of 8 to 20 years. Again, long timeline. People can have a shorter timeline, but they can be in this season for a long time. Compulsive use, drinking is primarily to feel normal. So they get into the substance use component where they're dependent on the substance, where they just have to drink to sort of feel baseline. Gets in the way, again, of jobs, relationships get worse. They maybe get into some major legal issues with drinking and driving. Generally, these individuals are drinking on a daily basis. And then we do get into some concerns about withdrawals becoming sort of dangerous for these individuals as far as like tremors, hallucinations, seizures, DTs, things like that. And then the final stage here of this is sort of the late stage complications. And again, timeline 10 to 30 years. This is where you get into the cirrhosis, hepatitis, pancreatitis type things, cognitive decline. So going back to the story of my uncle, he was in and out of treatment. Eventually, he was sort of gotten into the later stages of this, and he would go to detox for a period of time, have some sober time, and then he would go back to drinking alcohol. But when he would drink alcohol, it would make him so sick that he would vomit, and he couldn't keep the alcohol down. And so eventually, what happened is he was at home, and because he couldn't get the alcohol in his system or keep it in his system, he ended up having a seizure, and he died at his home. And my cousin went and found him a couple of days later when they hadn't heard from him. And so, again, a long timeline for him. He started drinking when he was a teenager, passed away when he was 42 years old. Again, just from some of the complications of alcohol use disorder. All right, when I do talks like this, I just have to keep putting the agenda up there to kind of reorient us to where we're at. So we talked about statistics, diagnosis criteria, and the progression of the disease process. I want to spend a little bit of time now kind of talking about the treatment options that are out there. And as we're talking about treatment options, essentially what I'm talking about is I want to talk about the gold standard in treatment for alcohol use disorder. So what is the best treatments that we know that are out there to help individuals that struggle with alcohol use disorder? And really what I'm trying to highlight here is that it's a combined approach for helping these individuals. So one of the options is we need to be prescribing medications for these patients, medications plus behavioral therapy, plus recovery support. All of that combined is sort of the gold standard, the best way to help individuals that struggle with alcohol use disorder. And again, as we think about alcohol use disorder, even as we're diagnosing it and having some of those initial conversations, I always want to make sure that we're remembering that this is a chronic sort of relapsing medical condition. So again, when we think about substance use disorders, we want to think about other chronic disease processes like diabetes or hypertension or asthma. Sometimes these patients' symptoms are going to fluctuate over time. Treatment is over a long period of time. It's not episodic. And again, just because someone returns to alcohol use or other substance use doesn't mean that it's a failure in our treatment necessarily. But it may signal that we need to adjust some things. And so, again, I think framing alcohol use disorder as a chronic disease helps kind of lower the shame and can help improve engagement for individuals. So the initial part of this is just the assessment. We talked about doing this DSM-5 criteria. There's some withdrawal risks about seizure history, daily heavy use, and then CIWA scores. Again, we'll talk more about that hopefully at a future presentation. And then we want to screen at this time for co-occurring conditions of depression, anxiety, PTSD, suicide risk in these individuals, and if they are using other substance use. The second thing highlighted in the gold standard here is evidence-based medication. So naltrexone is a really good medication, comes in a pill form and a shot form, helps with cravings and heavy drinking. Acamprosate is also an FDA-approved medication. Better data on this one if people are abstinent when they start using it, but it's still safe to use if people are still using some alcohol. And then in select cases, we use the disulfiram or the Antabuse, as it used to be called. And again, this is where most people's brains go in the general public about treating alcohol use disorder with medication. It's like, hey, isn't there a pill that sort of like makes me sick? Can I try that? Or why aren't we giving that more to patients? And again, in the right situation, we do that, but it doesn't help as much with cravings and desire to use. And so often what happens with that medication is people stop taking it, and then there's a return to alcohol use. So assessment, we should be offering medications to these individuals. And then again, the behavioral therapy is important as well in recovery support. So this includes things that we've talked about in the past, like motivational interviewing, relapse prevention skills around cognitive behavioral therapy and coping plans. lot of good support systems out there. AA is probably the one that's most well known. Smart Recovery is also a good resource. Also, individuals can seek out like a recovery coach or sort of a mentor. And then if people haven't sort of burned all the bridges with their family, having them engaged when appropriate and having them have a proper understanding of the sort of the chronic nature of this disease process can really be important for individuals' recovery. And then finally, we look at sort of chronic disease follow-up. So monitoring heavy drinking days, cravings, functionality, begin to treat some of the drivers of alcohol use. So sometimes that's insomnia. I talked about people complaining about sleep when I see them. Trauma can be a big reason that people use alcohol. Sometimes it be chronic pain or things like that. And then there are really helpful sort of step down options for individuals too. Maybe if they've gone to a treatment center, then they can step down into a residential or IOP. And that can be a helpful part of the solution as well. Most of that information is from the National Institute on Alcohol Abuse and Alcoholism. A lot of the information we get when we talk about substance use disorder treatment comes from SAMHSA. And again, just highlighting here that a combined approach, medications, psychosocial treatment, and recovery support is really the best model to be able to help these individuals. Again, it says offer medications when indicated. So naltrexone, acamprosate, disulfiram. And then again, pair the treatment combination with counseling and behavioral interventions as well. So if that's sort of the gold standard of treating alcohol use disorder, sort of my next question goes into like, so how are we doing in offering that in the United States, and how are we doing in providing this sort of treatment to individuals? And so again, comparing sort of alcohol use disorder and opiate use disorder, again, data from 2024, but essentially the prevalence of alcohol use disorder at this time was 28 million people above the age of 12 had a past year alcohol use disorder diagnosis. And in comparison, about 4.8 million people same age had a opiate use disorder. And when we look at treatment broadly for substance use disorders, only about 20% of people needing treatment for any substance use disorder received it in the past year in 2024. If we look more specifically at medicated assisted treatment for alcohol use disorder, and if we compare that to opiate use disorder, this data is from 2022, but about 18% of people with opiate use disorder received medication assisted treatment, so Suboxone or methadone in the past year. But again, if you compare that to people who struggle with alcohol use disorder, only about 2% of people with alcohol use disorder received any sort of medication assisted treatment in the past year. So again, highlighting that like, hey, the gold standard includes medication management for these individuals, but we're not doing a very great job of that. Again, sort of a summary statement along those lines. There's a larger number of people that have alcohol use disorder compared to opiate use disorder, but a smaller proportion of them receive medication specifically for alcohol use disorder compared to those with opiate use disorder. So the next sort of place my brain goes as I think through this is why is that the case? So we laid out that the gold standard should have medication associated with it. We're not doing a great job of prescribing patients medications for alcohol use disorder. And so why is that? And I do want to take a minute, so it's not just a long monologue. I want to open up that question to the group. So I want to hear your thoughts. I'm going to go over this slide, and then if you can put something in the chat, or if you want to sort of unmute yourself here in just a minute, I want you to try to answer this question of, hey, why are medications for alcohol use disorder so underused? And I would argue that one of the reasons is that patients seek care for alcohol use disorder rather late in the treatment process. So people struggle with alcohol use disorder for years. Some of the estimates are around 6 to 18 year delay from when alcohol use disorder treatment or alcohol use disorder onset to when people seek treatment. And again, this delay that means that some people may come into treatment only after crisis. When I think about my time in in the ER. This is where I saw my first patients with alcohol use disorder. And at that point in my career, I definitely wasn't starting anybody on any long-term medications for alcohol use disorder. And then again, the things that sort of trigger people to seek care is when they start to get into health consequences, family relationship pressure, work consequences, legal problems like DUI, fear of becoming dependent or losing control, and then withdrawal symptoms and an inability to stop. So I have a few more ideas on why medications for alcohol use disorder are underused, but I do want to open it up to the group here for a minute. Does there anybody have any thoughts of why this might be?
We've got provider knowledge in the chat.
Provider knowledge. Okay,
Yep.
great. Yeah, excellent.
Stigma.
Stigma. Any other thoughts on that one?
Did someone put denial in the chat?
Mm-hmm. Yeah, definitely.
Lack of specialization.
Okay.
Alcohol is
Lack
more
of sort of.
Yep. Alcohol is more accepted and used socially.
Mm-hmm. Absolutely. Kind of goes along with the stigma of needing help with that.
Local counselors, CBT in a smaller community. Maybe I think he means like
Mm-hmm.
lack of counselors, perhaps. Yeah.
Yep. Yeah, lack of services. Yep.
Lack of. Someone said they don't go to their medical provider for it. Um, and then Alex added, no specialty except addiction medicine wants to own this, and with lack of access, that means everyone passes the buck.
Mm-hmm. Yeah. Yeah, absolutely. Yeah, those are great.
Anyone
Those are
else?
really
Todd,
helpful.
Todd, did you have something? I saw you turned your video on.
Yeah. So I want to add to something, and Ed, you've done a great job today. I appreciate it. My role in this group is to be an advisor because I've been doing this for so long. So alcohol is kind of bread and butter to problems in Nebraska. Alcohol and tobacco are by far and away the biggest issues in Nebraska. We're fortunate to have funding for the grant. So if you look at the largest study that's been done for people that have alcohol use disorders, about 43,000 people. And in that study, and I'll come back to it in a minute, Ed has pointed there's 18 million people that have alcohol use disorder in the U.S. and roughly in any given year, and about 2 million get treatment. So what happens to those other 16 million? Well, from the studies that are out there, we looked at it wrong to begin with and didn't know it. Alcohol in the large majority of people, by far and away, it's a single episode that's not progressive, in which there are not a whole lot of other life complications that take place. And so not only is it not progressive, but that study dispelled a lot of other things too. That, for example, there's no such thing as addictive personality. Cross addiction is something that is overrepresented and not necessarily true. And so a lot of the answer to part of this question goes beyond kind of the stigma or awareness. It's that within that group, that large population that didn't get treatment, they only had a single episode and they didn't need it. That things got better in their life. They didn't have the medical problems or psychiatric comorbidity and so on. So I just wanted to put that in there because it is often alcohol use disorder is often thought of as chronic and progressive. In the small percentage of the population, that's true, but not in the larger numbers.
Thanks, Todd.
Yeah,
There's
thanks, Todd.
one more comment I wanted to read, and then I'll let you keep going, Ed. The last
Yeah.
comment we have here, patients think the only treatment is going to an inpatient facility, and obviously there's a lot of cost associated with that.
Mm-hmm. Yeah, absolutely. Yeah, that is one of the things of like, I need to be sick enough to go to inpatient to sort of to get the treatment. And again, these are some of the ones that.
Can I add one thing to that? Because I think it's an overlooked thing. So we're going to send somebody off to quote unquote rehab, right? Residential treatment. and so on, are originally founded in and by the founders of kind of AA and so on as 28 days. And here was the premise in finding it. The first week was to kind of take care of the physical problems, pay attention to the body and the detox and the withdrawal. The second and the third week were really focused on kind of education about the disease model, and the fourth week was placed on discharge plan. When you look at kind of the models over time, um, probably the best thing that residential treatment does is it prevents somebody from being around alcohol. But for those that have that chronic progressive nature, the spiritual awakening doesn't happen during those 28 days if you believe in the AA model and so on. So there's a lot of holes to poke in the quote unquote traditional 28-day model. Um, the other thing that happens in that model that's really, and I've seen it over and over and over through the years, when somebody has significant alcohol problems, your brain doesn't really come back online until about the end of that treatment time frame. It doesn't work to the extent of what it needs to process a lot of the information. So in actuality, the best thing that happens when somebody goes through alcohol treatment and goes to a residential program, it's hopefully to kind of clear up your thinking a little bit, and some of the physical symptom or physical manifestations of alcohol.
Yes, thank you. Um, Again, this was sort of the second slide of the things that I put together, which you guys have pretty much hit all of these, right? Limited access barriers, even medications available in treatment programs. Sometimes patients aren't started on medications, knowledge gaps, lack of knowledge around prescribing it, stigmas, mainly sending people to sort of inpatient stuff. Like all of those are reasons that medications are underused to treat alcohol use disorder. And so again, being a part of like Echo and what we're trying to do here, the next place I want to go is like, hey, how can we be a part of this solution in helping people with alcohol use disorder? We're going to see it in our practice, and so what ways can we be a part of the solution? And one of the ways I think that is really most helpful is early intervention. And we'll talk about how some of the medications that we can use can help us intervene sort of early on. So um, when we think about treatment options, I like to use this slide. It's just a really simple sort of slide that goes over the medication options for alcohol use disorder. So it talks about naltrexone, acamprosate, disulfiram, and then it adds a couple of other ones, topiramate and gabapentin. The first line there says whether these are FDA-approved medications or if they're used off-label to treat alcohol use disorder. And so again, this is just a sort of a helpful reference slide for you. I want to focus on naltrexone because we're going to talk more about that. Again, naltrexone, how does this medicine work? It's an opiate receptor antagonist, blocks the opiate receptors in our brain, helpful for reducing heavy drinking, helpful for relapse prevention, helpful for there's not any abuse potential with this medication. Again, I mentioned earlier, we do not have to be abstinent at the time of treatment, so people don't have to stop drinking to start naltrexone. And this is one that's not recommended in breastfeeding or pregnancy, but none of them are. So speaking of naltrexone, again, I want to highlight for you sort of the Sinclair method and what that is, and make sure that this is one of the tools that's in your toolbox to be able to help individuals with struggle with alcohol use disorder. So this is sort of an alternative method to treating alcohol use and abuse compared to what we've historically thought of as treatment, maybe in the inpatient setting. Or abstinence-based. And so the Sinclair method it's evidence-based treatment for alcohol use disorder where patients take the medication naltrexone before they drink alcohol. And essentially what we're doing is instead of forcing abstinence up front for individuals, we use what's called pharmacological extinction to retrain our brains so that alcohol loses this rewarding effect or this good feeling that we get from it. And essentially what happens is over time, cravings decrease. Many patients are able to sort of naturally reduce their alcohol use or even able to quit drinking sort of without going through this traditional sort of detox process that we've talked about in the past. Again, I highlight that this is sort of a different philosophy, and it uses this pharmacological extinction. And again, just a reminder on that, the best sort of thing that we have to remember pharmacological extinction is Ivan Pavlov's dog experiments. And again, you can remember those experiments where he would ring a bell and then he would bring food, and he would do that over and over again. And essentially, he could just ring the bell and not bring the food, and the dogs would begin to salivate just by the sound of the bell. And again, this the salivating for the dog is like this lower brain function. It's a sub non-conscious function, so lower brain. And so the thing that we sometimes forget about his research was that he could also sort of untrain the dogs to do that, right? So if he would continue to ring a bell but not bring food, essentially the dogs would stop salivating in that experiment. And so that's the idea of this pharmacological extinction. And essentially that's what we're doing with naltrexone. What patients do is they take naltrexone an hour before they drink alcohol. And what it does is it blocks that alcohol induced sort of endorphin release. And again, so when we drink alcohol, we get dopamine release, we get endorphin release. But if we repeatedly take naltrexone prior to drinking alcohol, we're going to unlearn this reward of drinking, or we're going to be able to maybe extinguish it for individuals. Essentially, their cravings diminish naturally, leads to reduced consumption or abstinence without sort of the forced withdrawals. The great thing about this is there's no mandatory detox, so patients don't have to quit drinking first. Compliance is always an issue, so patients do need to take this medication every time before they drink. They don't have to take it on non-drinking days, but it is important they take it before they use alcohol so that we can get this extinction process. And again, it works best for people that are motivated, that really want to quit drinking. It really kind of has to be the individual's desire to stop drinking, not just someone around them sort of pushing it. When you think about evidence around the Sinclair method, there's some trials that show 78% of individuals achieve significant reduction or abstinence within 4 to 12 months of doing the Sinclair method. There are lower relapse rates compared to detox alone. Unfortunately, acceptance of the Sinclair method is still a little bit limited in the United States, although this treatment option, it is more common in Europe. When I've done presentations in the past, and when I talk to patients, I give them this resource. It's called The Cure for Alcoholism by Roy Escapa. It goes over some of David Sinclair's research around it. And I think it's a really good read for individuals. And I think it's helpful for patients to sort of get their hands on this and study it. I do want to highlight, though, some other resources outside of that. So about a year ago, I went to the National ASAM conference. And when I went to the conference, it was out in Colorado. Because I have sort of a passion to treat alcohol use disorder and help people in those that struggle with that, I went to sort of all the talks on alcohol use disorder. And I was actually a little bit disappointed when I even went up and spoke to the speakers afterwards. There weren't a lot of people that were talking about naltrexone in sort of a Sinclair sort of method. Even when I went up and asked them, like, hey, have you heard of the Sinclair method, or are you trying it for any of your people? A lot of people were like, maybe, but not really. Like, they weren't for sure proponents of it. But when I went to one of the booths there, the PCSS booth, they had a little thing about alcohol. And the PCSS is the Provider Clinic Support System. And I asked them about the Sinclair method. Again, this was a year ago. I said, hey, have you guys heard of this? Are you doing any education around it? And they told me, they said, hey, we have heard of it. We're bringing more education out, and we're going to drop it in like July of 2025. And so, so sure enough, if you scan this code, you can go to their website, and they have a whole thing about the Sinclair method and how it sort of works to treat alcohol use disorder. I just want to go over a couple of the slides that they put together because I think they're helpful. Again, it sort of goes over what is the Sinclair method. It says the off-label approach for treating alcohol use disorder. Takes naltrexone before consuming alcohol. It can be used while people are still drinking with a goal of controlling alcohol. It talks about how it works, the same things we just went over. It blocks this opiate receptor, dampening the brain's release of endorphins, then and sort of doing this pharmacological extinction. It talks about how do you select a patient. We need to make sure that they have a diagnosis of alcohol use disorder. We talked about that. Maybe they're interested in reducing their alcohol, but not completely stopping. We do need to make sure that they're not using opiates, and that they're able to sort of self-manage taking their medications before they drink. Again, the advantage of this, non-abstinence-based goals, it's an alternative for patients not interested in traditional daily dosing of the medication. It empowers this autonomy for individuals, and flexibility around the individualized dosing. Again, it even goes into like some of the limitations, right? So people have to take it on a regular basis. They must be able to sort of anticipate and plan for when they're going to drink. And that there is still a risk of, acute alcohol withdrawal, and mild withdrawals as people are reducing or stopping their alcohol use. So things that we need to be mindful of. This, again, from their website, just goes over traditional alcohol use, sort of a traditional, naltrexone use for alcohol use disorder. Daily dosing, typically people are abstinent, taken on a daily basis to reduce cravings and prevent return to use. It also highlights the Sinclair method, which we've just been talking about. But they also offer a third option, which is sort of targeted naltrexone dosing. And essentially what that is people are not taking naltrexone every single day, but they're just taking it in anticipation of situations that may be high risk for them. So think of like weddings or some sort of event where they were or know they're going to be around alcohol. They can take the naltrexone for 1 to 3 days ahead of time, and it helps sort of with cravings and desire to use alcohol. And then if they do use alcohol in those settings, it is going to be helpful to cut back on that. This is a protocol that they put together. It gives you a little bit more of a guideline, day-to-day sort of goals of reducing alcohol use in a 7-day period. Again, when I think of the Sinclair method over a 28-day period, if somebody's drinking on a daily basis, I don't think that we're maybe going to be able to reduce the alcohol quite as quickly. But if you think of this protocol of day 1 through 7 of drinking days, a lot of times the patients that I see are drinking maybe 2 or 3 times a week, maybe even less than that. And so if you think of 7 days of taking naltrexone prior to alcohol use, and then you're trying to reduce, your alcoholic drinks by 1 or 2 or 3 over the next period of drinking days, this protocol really gets stretched out over to, several months, which I think is more consistent with some of the other data that I've looked at. I will highlight a couple things here on this protocol. Generally, we start the dosing with 50 milligrams on drinking days. Definitely can start with 25 milligrams for the first week to minimize some of the side effects of naltrexone. Most people tolerate the medicine really well. Some people do report some fatigue with the medication. The other thing that you can do is if people are doing the Sinclair method, you can bump their dose up to 100 milligrams a day if you're not getting the sort of response that you want as far as reducing the alcohol use. So bumping it up to 100 milligrams is also an option there. Again, research findings around this, no randomized controlled trials, but they do quote this combined study with multiple participants that showed that daily naltrexone led to higher percentage of abstinence and reduced risk of alcohol use. Again, the other book quotes that one, and other resources do as well. Not going to spend time on this slide apart from just like, hey, there's a lot of great resources at the PCSS. It's a free resource to go to. They do great little videos and talk about some different topics around alcohol use disorder. Finally, from a sort of research side, I guess I have 2 more thoughts on it. This is the tip 49 from SAMHSA, incorporating alcohol pharmacology into medical practice. Again, just highlighting a couple things from this tip. The Sinclair method is sort of interwoven into it, where it talks about alcohol's reward effects being in the opiate system. Opiate antagonism reduces this reward signaling, so weakening the reinforcement of drinking. Naltrexone in that third point reduces cravings and urges to drink, blocks this pleasure from alcohol, can reduce the amount of heavy drinking in those who drink. Again, brief medical management was effective in lowering alcohol use on that combined study, again, with naltrexone. And I will just highlight, if you read that whole document, it has a large push towards an abstinence-based treatment model, which, again, is probably what we think about most often. but there is some data in there around the Sinclair method. And then finally, here's just a few from a research of just like, hey, there's other things out there about naltrexone. We're starting to see more sort of news clippings about naltrexone. So wherever you get your news from, it says little known prescription pill is helping Americans drink less alcohol, talking about naltrexone blocking opiate receptors and reducing cravings. Why a promising treatment for alcohol abuse is barely used. Again, talk about naltrexone underutilization. Looking to cut back on wine or beer, this pill might help you. Targeted naltrexone before drinking. And then again, a decades-old drug is helping people drink less alcohol without giving it up completely. And so, again, I'm just highlighting that, like, hey, although acceptance has not been like widespread in the United States, we are seeing more movement towards education and talk about the Sinclair method. And so I'm really excited about that. Okay, going back to kind of beginning to wrap us up here. I'm showing you the timeline again that we talked about in a more concise way. But as I look at this timeline, I think that naltrexone fits into the picture multiple times if we can have conversations about alcohol with individuals that we're seeing. So early on, low risk experimental use, typical timeline in the teens and 20s. Again, if we're asking people like, hey, are you using alcohol? Are you experimenting with alcohol? Is it becoming a problem? Do you have a family history of alcohol issues? Hey, I just want you to know that if alcohol does become a problem for you, there are some medications that we can try to help individuals reduce their alcohol use, right? We're sort of planting the seed early on for individuals that like, hey, I can have a conversation about this and there may be some options for me. Again, as we go into the typical at-risk use, 6 months to 5 years, hopefully in 5 years, we're seeing patients in a primary care setting or they're seeing a doctor, maybe not. But like, again, are we having questions? Are you using alcohol? People generally underreport how much alcohol they're using, but just having the conversation of like, hey, if alcohol is becoming a problem or this is how it tends to progress, there are medications like naltrexone. You don't have to take this medicine every single day. You only have to take it when you are drinking alcohol. The third point there, hazardous use. Again, binge patterns. We talked about that in Nebraska being significantly high, but it could be as big of a 10-year period of someone's life where they're binging on alcohol or using it, and this may be a time where we can introduce it. I think patients do really, really well. I'm thinking of a patient that I saw not that long ago that was started on naltrexone. He was binge drinking 10 to 20 beers on the weekends. Went on a trip with his buddies. Had started doing the naltrexone. Came back and saw me, and he was super excited. He's like, "Listen, I went on a golf trip. I drank 8 beers throughout the whole day. Usually I would have drank over 20 and been blackout drunk. Super helpful for me to not drink as much." And so, again, I think this is really helpful. And again, mild alcohol use, moderate alcohol use, I'll at least offer the Sinclair method to people. I'll say, hey, here's your options. We can try to stop drinking and never go back to it again, and we can use medications, or we can try the Sinclair method, and that can help reduce your alcohol use. It gets a little bit more complicated when you get into severe alcohol use disorder. But again, I want people to have the option for that. And the other thing I want to sort of drive home as we close our time is if somebody goes to detox and they actually go to treatment and they start on naltrexone, I always want to encourage those individuals, say like, hey, my goal for you is that you're never going to use alcohol again. That's my overall goal for you. But if you do, I don't want you to stop taking naltrexone. Keep taking the medication, even if you have a return to use. And this sort of gives people something that they can sort of grasp onto of like, hey, what happens if I do have a return to use, and what can I do in that situation? Again, this is kind of as I think about my uncle and bring it back to him again, who knows if he was offered the Sinclair method? I don't know specifically, but I doubt it. But could it have changed his life? Could it have changed his progression of all the times he was in and out of treatment? Could that have been one of the solutions that were offered to him and possibly had a different outcome? I do need to just put in the contraindications and cautions. So people can't be using opiates. Kratom 7-OH, we're going to talk about that in a few weeks, can cause precipitated withdrawals, hypersensitivity to naltrexone, and then acute hepatitis or liver failure. As far as active liver disease, LFTs need to be above like 3 to 5 times the normal limit before it's maybe problematic. Generally speaking, the way I address this is if they have physical symptoms of liver problems, I maybe hold off on naltrexone until I can get some labs. And if it's significant enough, I'll send them off to specialty. Do need to be mindful of opiate analgesic for any sort of surgery. They can stop the naltrexone. Shouldn't be using it during pregnancy. Some cautions there around renal impairment and then depression and suicidality. All right, well, I had a case study, but we're obviously not going to get to that. So let me just kind of stop here again and open it up for any final questions or thoughts.
Okay, thanks, Ed. A great presentation. Yeah, we've got like 5 minutes, so feel free to speak up or drop questions in the chat. There was a question in the chat earlier, and Alex did a good job of answering that, so I don't think we need to go back to that one. But we can just kind of take a minute here and see if anyone has any questions or thoughts. Question: Any studies on GLP-1s with alcohol use disorder?
Yeah, that's a great question. One that kind of get pretty frequently. So I think the way that I know right now is that they're researching it. I don't know that there's any labels around GLP-1s around stopping alcohol use disorder, but anybody that you talk to that's in the GLP-1 world or in sort of the substance use world has heard people talk about, I got started on my GLP-1 and all of a sudden I lost all interest in alcohol and just sort of stopped drinking or reduced it significantly. And so I don't know that we fully understand all that's going on with GLP-1s. A lot of it is really good stuff. But the answer is yes, for some individuals, we've seen a significant reduction in alcohol use, but I don't know at this point that there's any specific studies.
Thank you. Alex dropped in a link. Looks like it's related to some research on this topic. So y'all can check that link out. While we're waiting here, we just got a couple minutes left. I did drop in a link to the evaluation survey. You can grab that now. I'll also be emailing that out later. Here's a question. Can you provide a list of outpatient counselors, resources to use/call with questions or when patients are ready to cut down or quit alcohol?
Yeah, that's a good question. So the way that runs with the company that I work for, we sort of have a preset thing of like all the counselors and things that are close. We could definitely run something down for you as far as like counseling and therapy that could be close to you. There are a lot of online options for individuals as far as like support groups and counseling as well. I also just wanted to briefly say, like, I launched a website a year ago where I can do telemedicine options to treat patients with alcohol use disorder. And again, just being able to offer sort of the naltrexone, evaluate these patients and help them. But definitely, like, part of what Echo does too is we're trying to be a resource. So, like, hey, if you're in a certain area and you have questions about who can get treatment or where they can get treatment or recommendations, you can definitely reach out to us and we can do a little legwork to try to help an individual in a certain spot.
Yep, absolutely. Yeah. Yep. So Michael, if you have a specific area, kind of you're working in, maybe shoot me an email and I can kind of work with the team and see if we can find some recommendations for you.
One of the things I've been doing too is I've been going to different counseling services and educating them at times as well, more on alcohol use disorder, and that being a good resource of people already seeking counseling to think about the sort of the gold standard approach of more medication options.
Great. Let's see, there's a comment in the chat from Asia about services that Nebraska Indian Health Coalition offers. So Michael, who asked the question, you can see that there. And Alex dropped in a comment about One World also. Okay, so I think, yeah, looks like we're at the end of our hour here, so we will call it there. And like I said, we will be off in March, planning for April and May. So just keep an eye out for more information on that, and hope to see everyone back in April, May when we start our new cycle of 4 trainings. And then Echo team, if you guys want to jump over to that other link, we'll do just a real quick team meeting. Thanks, everybody. Happy Friday.